Hello, welcome to week 6 content session for NU 621 Advanced Pathophysiology. My name is Dr. Christy Burks. This week, the content is a little bit heavy. We are looking at quite a few things, but some of this should be just a review, and then some of it, hopefully you have time to dive in deeper to these content disorders. So we're going to be looking at mental health disorders, neurological disorders. Some of the topics include PTSD, depression, anxiety, GAD, schizophrenia, bipolar. We're also going to be looking at sleep disorders, headaches versus migraines, strokes, seizures, some head injuries, and then even Parkinson's and Alzheimer's, and if maybe even fibromyalgia if we have time. So first, we're going to review the pathophysiology and neurobiological changes of a few mental health disorders. So beginning with post-traumatic stress disorder, the pathophysiology of PTSD primarily involves the dysregulation in the neural circuits involved in fear and stress responses. So particularly the amygdala and the prefrontal cortex and the hippocampus. Now, the amygdala plays a key role in fear conditioning and shows increased activity in PTSD when exposed to trauma-related stimuli. So the prefrontal cortex normally inhibits the amygdala's fear response, but the inhibitory control is diminished in those with PTSD. So when you refer to this figure here from the textbook, to help you recall the location of the hippocampus, the hippocampus is involved in memory formation and contextual processing of events. So structural brain imaging studies actually show that there's a reduced hippocampal volume in individuals with PTSD, which may actually contribute to persistence of that traumatic memories and difficulty regulating fear responses. So the hippocampal atrophy is thought to result from the neurotoxic effects of chronic stress and elevated glucocorticoid levels. Other brain changes observed in PTSD include decreased volume in the anterior cingulate cortex, which is involved in emotion regulation, and increased activity in the insula, which processes the bodily sensations related to anxiety and arousal. So if you remember correctly, the insula is in the region of the cerebral cortex, folded deep within the lateral sulcus. It plays a critical role in processing those body sensations like pain, temperature, itch, visceral sensations from the gut. So the insula is also involved in emotional experiences, particularly the negative emotions like disgust, anxiety, and even anger. It integrates the sensory information, which with emotional and motivational signals to produce subjective feelings and conscious awareness of those body states. So, dysfunction of the insula has been implicated in conditions like anxiety, disorders, um, addiction, and even those somatoform disorders involving the distorted body perception. There's also evidence of reduced hippocampal volume in those patients with PTSD that we talked about. The textbook actually mentions that those structural brain imaging studies show that combat exposed PTSD victims have a smaller hippocampus compared to the controls in their study. Overall, the neurobiological alterations in PTSD reflect that dysregulated fear circuitry and impaired fear extinction. So now looking at the textbook, box 19.2, at the major symptoms of depression and mania. So first we're going to go into bipolar disorder. So this mood disorder involves dysregulation of the neurotransmitter systems like dopamine, serotonin, and even norepinephrine. So during manic episodes, there's an increased activity in the amygdala and decreased prefrontal cortex regulation. So depressive episodes are marked by underactivity in the reward pathways. Structural changes like decreased hippocampal volume also may contribute to this. The brain abnormalities observed during manic and depressive episodes of bipolar disorder differ significantly. So during a manic episode, there's an increased activity in the amygdala, which is involved in that emotional processing. There's also decreased regulation from the prefrontal cortex over the amygdala's activity. And this dysregulation contributes to the elevated mood, impulsivity, and poor judgment seen in mania. Conversely, during the depressive episode, there's an underactivity in the brain's reward pathways, including the amygdala and prefrontal regions. So the hippocampus, which plays a role in that memory and emotional regulation, also shows decreased volume in both manic and depressive states. However, the overall pattern is one of overactive limbic system during mania and an underactive reward circuit during that depression. Another type of mood disorder that we see is major depressive disorder. So deficits in the monoamine neurotransmitters like serotonin, norepinephrine, and the dopamine pathways, which underlie the core mood dysregulation. So the hippocampus shows decreased neurogenesis, and that hyperactivity of the hypothalamic pituitary adrenal axis stress response system and elevated cortisol levels further disrupt the neurotransmitter balance and neuroplasticity. Now, in this figure 19.9, it gives you just kind of a visual of the limbic system. So as we talk about general anxiety disorder, that is why I included this, just to kind of help remind you of the limbic system and the role it plays in emotion, learning, and memory. So the pathophysiology of general anxiety disorder involves the hyperarousal of the amygdala and failure of the prefrontal cortex to inhibit the fear response plays a central role on this. So the imbalances or reduced activity in neurotransmitters like GABA, your serotonin, and norepinephrine disrupt the regulation of the hypothalamic pituitary adrenal axis stress response system. So genetic environmental factors influence susceptibility. Environmental factors like stressful events, life events, trauma, abuse, chronic medical conditions, and even substance abuse. And then childhood adversity, such as parental neglect or an unstable family environment, can actually increase the risk of this. Ongoing stress from work, relationships, and or financial difficulties can also trigger or exacerbate the GAD symptoms. So in that general anxiety disorder. Additionally, having limited coping mechanisms or poor social support networks may actually contribute to the development of GAD. In this next box, it's from the textbook 19.1. It's the major symptoms of schizophrenia, and it's positive versus negative. So when we talk about schizophrenia, this psychotic disorder stems from disrupted dopamine signaling, particularly in the mesolimbic pathway. So increased dopamine activity in areas like the stratum contributes to those positive symptoms like delusions and hallucinations. And then negative symptoms are linked more to the decreased dopamine in the prefrontal cortex. Now, structural brain abnormalities like enlarged ventricles are also implicated in this as well. Make sure you review the major symptoms of schizophrenia, kind of categorizing them in the positive versus negative symptoms. The textbook goes into the dysfunction in the prefrontal cortex, particularly the dorsolateral prefrontal cortex, or the DLPFC, which is linked to the negative symptoms and cognitive impairments observed in schizophrenia. And the DLPFC is involved in executive functions like working memory, attention, and goal-directed behavior. In schizophrenia, the DLPFC shows hypoactivity and reduced blood flow, metabolism during cognitive tasks. So this prefrontal cortex dysfunction contributes to deficits in working memory, attention, and initiation of goal-directed activities seen in schizophrenia patients. The progressive loss of frontal lobe gray matter volume is also associated with increased negative symptoms severity over time. So Other disorders to review include like your panic attack or panic disorders, social anxiety disorders or phobias, and even obsessive compulsive disorders. So the chapters that we look at this week will go deeper into that as well. Next, we're going to look at the common types of headaches. Which include tension headaches, migraines, cluster headaches, and even sinus headaches. So table 18.14 goes over the characteristics of common headaches. So starting with tension headaches, they tend to be dull, non-pulsating pain that feels like a tight band around the head, often related to stress or muscle tightness in the neck and shoulders. This image from the pathophysiology made incredibly visual is pathways of the migraine. So when we talk about migraines, this is more severe pulsating, often one-sided headaches that can result or last from 4 hours to up to even 72 hours. It's associated typically with nausea, vomiting. It can be, they can have light sound sensitivity. These patients actually may or these migraines may actually be preceded by an aura of visual disturbances as well. In our calcitonin gene related peptide, that's CGRP, which is a potent vasodilator that plays a major role in the pathophysiology of these migraines. So during a migraine attack, CGRP is released, leading to vasodilation of cerebral and dural blood vessels and activation of the trigeminal nociceptors and inflammatory mediators. So this dilation is thought to contribute to throbbing pain sensation characteristics of the migraines. CGRP also sensitizes trigeminal nerve fibers, so facilitating the transmission of nociceptive signals to the brain. The newest class of migraine preventative medications are the CGRP receptor antagonist, and they work by blocking that CGRP and its vasodilatory and pain signaling effects. Now, in cortical spreading depolarization, or CSD, which is that wave of neuronal and glial depolarization that propagates slowly across the cerebral cortex, it is characterized by a massive efflux of potassium and influx of calcium ions, leading to neuronal swelling and the disruption of ionic gradients. CSD is believed to be the underlying mechanism of the migraine aura, which involves that transient neurological symptoms like the visual disturbances or sensory changes. Now, the depolarization wave is thought to cause changes in the cerebral blood flow, which release of the inflammatory mediators like CGRP and activation of the trigeminal nociceptors, ultimately triggering the migraine headache pain. So CSD may also contribute to stroke injury by exacerbating ischemic damage in the brain tissue as well. Next, just looking at briefly at cluster headaches. So those types of headaches are more excruciating pain, usually around one eye or temple. They can occur in clusters of short but extremely painful attacks, and they tend to be more common in men. Sinus headaches, which is pain in the forehead, cheeks, and the bridge of the nose, often accompanied by sinus stuffiness, fever, and even facial swelling. So each type of the headaches or migraines have distinctive characteristics in terms of the pain quality, location, duration, associated symptoms that aid in diagnosis and treatment. So it's important for you to know and understand the differences between those. Let's see. And when we look at the dysfunction that can also contribute to various pathological conditions that may play into headaches and or migraines, we've studied over the past few weeks several different disease processes or conditions that could play a part into this. So, for example, hormonal imbalances. We know that the hormonal imbalances, the hypothalamus produces releasing and inhibiting hormones that control the secretion of pituitary hormones. So hypothalamic disorders can lead to hormonal deficiencies or excess affecting growth, metabolism, stress response, and even reproductive function. We can have thermal regulation problems. The hypothalamus regulates the body temperature, so its dysfunction may cause fever. Oops, sorry, hon. All right. Fever, heat intolerance, or the inability to regulate temperature properly. All right, moving on. Next, we're going to talk about two main types of CVAs, or cerebrovascular accidents. So we have ischemic stroke, which is caused by a blockage or occlusion in the blood vessels supplying the brain, depriving brain tissue of oxygen and nutrients. So this can be due to a thrombus or a clot forming locally, or an embolus, which is traveling clot or plaque fragment, versus your hemorrhagic stroke, which is caused by a rupture or leakage of blood vessel in or around the brain. This can be intracerebral hemorrhage, bleeding within the brain tissue, or subarachnoid hemorrhage, which is bleeding into the space surrounding the brain. The textbook in box 18.1 shows the risk factors of stroke, which include poorly controlled or uncontrolled atrial hypertension, smoking, which increases the risk of stroke by 2 to 4 times, and then atrial fibrillation, which is an arrhythmia that we see that can lead to diabetes mellitus, can increase your risk for stroke, congestive heart disease, PVD, chronic kidney disease, and several others that are listed there. Additionally, transischemic attacks, or TIAs, are temporary disruptions of blood flow causing reversible neurological deficits. Often these are warning signs of an impending stroke, larger stroke. So a TIA, again, is caused by a temporary reduction in that cerebral blood flow, and often due to just a brief occlusion of the cerebral artery by a small clot or plaque debris. So this transient blockage reduces oxygen and nutrients supply to the part of the brain, leading to those temporary neurological deficits. All right, a common pathophysiological element in both types of strokes and TIAs include sudden reduction in cerebral perfusion or blood flow to the brain. In this table, 18.12, it shows the signs and symptoms of stroke involving major cerebral vessels. The location of the stroke in the brain determines the types of neurological deficits and symptoms that can occur. The brain is divided into specific functional areas, so the effects depend on which region is damaged by the stroke. For example, a stroke in the left hemisphere, which controls language in most people, can cause aphasia, which is that difficulty with speech and language. A right hemisphere stroke may lead to neglect or unawareness of the opposite side of the body or visual field. And then strokes in the cerebellum impair coordination and balance. And then brainstem strokes can actually affect basic functions like breathing, heart rate, conscious level. So again, the specific deficits help localize where the brain and the stroke actually occurred. When you think of stroke symptoms, how does a stroke affect a person with, when you think of, with the sudden onset of focal neurological deficits causing symptoms such as that face drooping, arm weakness, sometimes in the leg, especially on one side of the body. Sometimes there's speech difficulty, numbness of the face, arm, or leg, especially on one side of the body as well. Confusion, trouble speaking or understanding speech, and then trouble walking, like and dizziness, loss of balance or coordination, and even that sudden severe headache with no known cause. So in this, I think I posted it. I'll look and make sure that I posted on the synchronous session schedule and links under additional information for you to look at. This FAST experience is an interactive game, and I've got this website here. So it's good for our patients or family members, and it's a good resource for them to help with education on recognizing. And it actually does an interactive portion showing you different aspects of what it could look like if you're having a stroke, or if a family member or somebody that you know is having a stroke. All right, next we're going to go into seizures. So the main types of seizures include generalized onset seizures like tonic-clonic seizures, absence seizures. Um, think of on absent seizures, think of like a blank stare into space. This may be repetitive, but it's brief when it occurs. Tonic seizures, which is like the stiffening of muscles, which can cause people to fall or even lose consciousness. Then we have clonic seizures, which typically include that jerking movements and a rhythm and are repetitive as well. We also have myoclonic seizures and atonic seizures as well. So looking first at generalized onset seizures like tonic-clonic and absent seizures involves abnormal excessive neuronal firing that starts in both cerebral hemispheres simultaneously. So this often is due to an imbalance between excitatory and inhibitory neurotransmitters. When we think of focal onset or partial seizures, this is simple partial seizures or complex partial seizures. Um, Focal onset or partial seizures originate in a localized area or network in one hemisphere. So simple partial seizures occur when only a small area is involved, when complex partial seizures engage a larger region, including the temporal lobe. The seizure activity may remain localized or even spread to other parts of the brain. Clinical manifestations of a complex partial seizure include focal onset seizures, which could present as impaired awareness, lip smacking, repetitive hand movements, even postictal confusion are very characteristic of complex partial seizures. When we think of those complex partial seizures, they originate from one area or network in the brain, often that temporal lobe. So they definitely cause an impaired consciousness or responsiveness during that seizure time, along with what we talked about, that lip smacking. Sometimes it looks as like they're chewing or that repetitive motor movements. Other types. So there is an unknown onset seizures and seizures that start as focal and become generalized. So the underlying causes include genetic factors, structural brain lesions, metabolic disturbances, head trauma, tumors, stroke, and other brain injuries or disorders that disrupt the normal neuronal signaling. The seizure type is typically classified based on where it originates in the brain, the level of awareness, consciousness during the seizure, and other clinical features like muscle stiffening, jerking movements, etc. Classification of seizures and epilepsies in the table 18.10. So it kind of goes over that a little bit more specifically. When we think of epilepsy, the pathophysiology of epilepsy involves that abnormal excessive neuronal activity in the brain leading to recurrent seizures. Some key mechanisms to remember about that include the imbalance between the excitatory and inhibitory neurotransmitters like glutamate and GABA. Then also the disruption of ion channels that regulate neuronal excitability, the structural brain lesions or scarring that create abnormal electrical circuits, genetic mutations affecting neuronal signaling pathways. There can be metabolic disturbances altering the brain biochemistry. And lastly, so your brain injuries from trauma, stroke, tumors, or even infections can play a part. The excessive hypersynchronous neuronal firing in the cerebral cortex spreads to larger brain regions, and this causing the clinical manifestations of seizures depending on the location again and extent of the abnormal electrical activity. So epilepsy results when that abnormal brain activity becomes recurrent and chronic. The last thing I want to talk about with seizures is the status epilepticus. So a tonic-clonic seizure lasting 15 minutes or longer without regaining consciousness between seizure events is classified as status epilepticus. Status epilepticus is a life-threatening medical emergency that requires immediate treatment to stop the prolonged seizure activity and prevent that permanent brain damage, disability, or even death. It's characterized by that continuous seizures or rapidly repeating seizures without any time of recovery of consciousness in between. So prompt treatment with benzodiazepines, anti-seizure medications, and definitely some supportive care is very crucial to help terminate this. Next, looking at neurodegenerative disorders, we have Alzheimer's, pardon me, Parkinson's disease, ALS, MS. These are just a few neurodegenerative disorders that we're going to talk about briefly. So they involve the progressive degeneration and death of neurons in the central nervous system, so leading to impairments in cognitive, motor, and other neurological functions. So while the specific pathological mechanisms differ, these diseases share common features of neuroinflammation, protein misfolding, oxidative stress, and ultimately irreversible neuronal loss over time. In table 17.24, it reviews Parkinson's, ALS, Huntington's, myasthenia gravis, and MS, or multiple sclerosis, just looking at a few of these. So be sure to go over this a little bit better. Parkinson's disease, which we know the pathogenesis of primary Parkinson's is not known. However, there are several different types of gene mutations identified, including the alpha synuclein misfolding or aggregation in cortical neurons, which is the cause of the cognitive decline and visual hallucinations. It's classified as a neurodegenerative disorder and is a loss of dopamine producing neurons in the brain. This dopamine deficiency impairs the basal ganglia motor circuits. So this leads to the characteristic movement disorders like the bradykinesia, the rigidity, the resting tremors, and the postural instability. In ALS, we see the degeneration of upper and lower motor neurons in the brain and spinal cord that causes progressive muscle weakness, atrophy, and even paralysis. The exact cause is unknown, but proposed mechanisms do include that oxidative stress, the glutamate exotoxicity, and protein misfolding, and the mitochondrial dysfunction and impaired axonal transport leading to that motor neuron death. Now, the pathophysiological mechanisms of MS involve an autoimmune attack on the myelin sheaths that insulate the nerve fibers in the central nervous system. So this demyelation disrupts the conduction of nerve impulses. This leads to a variety of neurological symptoms. So the immune system mistakenly targets the myelin as foreign and recruits inflammatory cells like T cells and antibodies to attack it, forming lesions or plaques. Initially, the body attempts to remyelate, and over time, the repeated demyelation leads to axonal damage and neurodegeneration. So the areas commonly affected include the optic nerve, brainstem, spinal cord, cerebellum, and even the cerebellum. So while the exact trigger is not known, genetic and environmental factors like viral infections are thought to play a role in this autoimmune process. Last one we're going to look at is the Guillain-Barré syndrome, or GBS patho. This is rare. It's a demyelinating disorder that is caused by antibody and cell-mediated immunological reaction, or an autoimmune attack, again, on the peripheral nerves. So this is such as the Schwann cells, which are the most common cell types in the peripheral nervous system. Clinical manifestations include tingling and weakness to ascending flaccid paralysis. So starting in the legs, and it can progress to complete quadriplegia, respiratory insufficiency, and even autonomic nervous system instability like low blood pressure and arrhythmias. Real quick, I want to talk about different types of pain. So we have a visceral or nociceptive pain, which arises from internal organs. So think of your appendix or gallbladder and different types of body cavities. This pain is typically described as dull, aching, cramping, and it's poorly localized. Visceral pain often refers or radiates to other areas and is associated with nausea, vomiting, hemodynamic changes, and can be also sharp and well localized pain as well. So if you think about that appendix of like appendicitis or gallbladder attacks. Then we have neuropathic pain, which results from injury or dysfunction of the sensory nervous system itself. It presents as burning, shooting, electrical, or stabbing sensations along the affected nerve distribution. So that is something to think about. Next one is central sensitization pain. This involves the hyperexcitability of neurons in the central nervous system that amplify and prolong the pain signals. It can occur with persistent nociceptive input and leads to that widespread diffuse pain hypersensitivity. So think of our disease processes like fibromyalgia, where they experience that diffuse pain all over the body, especially in response to light pressure. The last one we're going to talk about is somatic nociceptive pain, which originates from musculoskeletal structures like skin, muscle, bone, joints, or connective tissue. It's typically well localized as sharp or aching pain corresponding to the site of injury or inflammation. Somatic pain can be cutaneous or that superficial or even deep, depending on the affected structures. The image from the book, which is figure 16.5, looks at sites of referred pain. So that's something to look at as well. Quickly, we're going to go over a little bit of Alzheimer's disease. So in different types. So when we think of different types of dementia, Alzheimer's disease is one of them. We also see vascular dementia, Lewy body dementia, frontal temporal dementia, mixed dementia. And then there's others such as Parkinson's disease dementia, Creutzfeldt-Jacobs disease, and then Wernicke-Korsakoff syndrome. There's normal pressure hydrocephalus and even early onset dementias that occur before age 65. So starting with Alzheimer's disease, which is one of the most common types of dementia. And the textbook does offer figure 17.15 and table 17.16, just as some visuals to help you with learning. The figure compares a normal brain to a brain with Alzheimer's. So I thought this was a good visual representation whenever you're thinking of this disease process. The pathophysiology involves the abnormal accumulation of the amyloid beta proteins forming plaques outside the neurons and tau proteins forming that neurofibrillary tangles inside neurons. So this leads to that synaptic dysfunction, the neuroinflammation, the oxidative stress, and eventually widespread neuronal death, particularly in the hippocampus and cerebral cortex responsible for memory and cognition. So the table then goes over the progression of Alzheimer's. So that is something to go over and make sure you understand a little bit more. Next, we're going to go over vascular dementia, which is caused by conditions that damage the blood vessels in the brain and impair blood flow like strokes. So we see an abrupt onset of symptoms following a stroke. Stepwise, we have a progression of cognitive decline with periods of stability between declines. You see memory deficits, especially for recent events, and then impaired judgment, reasoning, and even problem solving abilities. Personality and mood changes like apathy or depression. We have difficulties with motor function like slowed movements or poor coordination, urinary symptoms like urgency, frequency, or even incontinence, and then potential focal neurological deficits like weakness on one side of the body. Symptoms usually depend on the location and severity of the vascular lesions, but vascular dementia is typically characterized by a patchy distribution of cognitive impairments compared to the global deficits in Alzheimer's disease that we see. Now, again, we have Lewy body, which is those dementia, which is the abnormal deposits of the protein in the brain where it disrupts thinking, movement, and behavior. We have that frontotemporal dementia, which is the degeneration of the frontal and temporal lobes that impacts behavior, personality, and language skills. And mixed dementia, which is a combination of two or more types of dementia. Commonly, we see Alzheimer's and vascular dementia. Now, we also do see delirium symptoms, so acute dysfunction of neurotransmitters, so the neglect syndrome. For example, after neglect syndrome, common after stroke, it's generally in the right hemisphere where the entire complex of sensory inattentiveness and loss of recognition of one's own body parts in extinction. All right. I think I had, the pathophysiology made visual. It had a good just visual on the 5 A's of dementia that I wanted to just share with you guys. I thought it was a good visual. It has amnesia, agnosia, apraxia, and apathy and aphasia. All right, next we're going to go over brain injuries. So when we're thinking about brain injuries, a primary brain injury occurs at the moment of the traumatic impact and results from the mechanical forces applied directly to the brain tissue. It can be classified as focal or diffuse. In a focal brain injury, this causes localized damage like contusions or hemorrhages, or even skull fractures in the specific area of the brain. Versus diffuse injury involves that widespread damage to axons through the white matter. Hang on just a moment. Okay, sorry about that. I had to pause for just a second. I'm just going to start over. So when we're thinking of a brain injury, a primary brain injury occurs at the moment of that traumatic impact and results from mechanical forces applied directly to the brain tissue. It can be classified as focal or diffuse. In focal brain injury, it causes localized damage like contusions, hemorrhages, or even skull fractures in the specific area of the brain, whereas diffuse injury involves that widespread damage to axons throughout the white matter. The white matter tracks from the shearing or stretching forces known as diffuse axonal injury. So primary injuries are also categorized as open or closed based on whether the skull and dura are penetrated, and the severity depends on the type and magnitude of forces involved in the trauma. Pardon me. All right, the pathophysiology of traumatic brain injury, so the TBI, involves primary and secondary mechanisms. In our primary injury, it occurs at the moment of the trauma due to the mechanical forces applied to the brain injury. This can result in focal injuries like contusions, hemorrhages, and even skull fractures, or even those diffuse axonal injury from the shearing and stretching of the axons. Secondary injury can develop over hours to days through a cascade of cellular and molecular events triggered by the initial trauma. This can include that inflammation, excitotoxicity, oxidative stress, and even disrupted cerebral blood flow, edema, and ultimately that widespread neuronal death. The severity definitely depends on the type and magnitude of the primary injury, with more severe primary injuries leading to that exacerbated secondary injury process that worsen their outcomes. In DAI, or diffuse axonal injury, this involves that widespread damage to axons, the long projections of the neurons throughout the brain. So it results from traumatic acceleration and deceleration, rotational forces that can cause shearing and that stretching of these delicate axonal fibers. The mechanical forces tend to tear and disrupt those axons, impairing the communication between neurons. So DAI injuries, diffuse axonal injuries, often are microscopic initially, but can lead to punctuate hemorrhages, where axons and small vessels are torn. And over time, enough axonal damage can actually cause significant cognitive, behavioral, and even physical impairments. So DAI may also trigger chronic neurodegenerative processes like chronic traumatic encephalopathy as well. Now in figure 18.3, this is an image of cerebral contusion, and 18.1 table classification of brain injuries looking at concussion versus contusion, and then primary brain injuries. So when we look at a concussion, it's a mild traumatic brain injury caused by a direct impact or impulsive force that transmits acceleration and deceleration forces to the brain. It typically results in temporary neurological dysfunction without visible structural brain damage. So take someone who gets hit in the head. They actually may lose consciousness for a bit and can even have confusion and a headache, but there are no abnormalities shown when imaging is done. A contusion, on the other hand, involves bruising of the brain tissue due to the impact, often with bleeding and swelling at the site of injury. So contusions are considered more severe focal injuries that can be seen on neuroimaging, while concussions actually may resolve within days or weeks. Contusions carry a higher risk of complications like increased intracranial pressure and even herniation. Both injuries initiate inflammatory and metabolic cascades that can lead to further neuronal damage if they're not properly managed. All right, I know week 6 is a heavier week than our past 2 weeks, and so is week 7. So please make sure you're looking ahead and planning accordingly for the content and for those assignments. The last thing I'm going to mention once again is we are getting closer to week 8, and this is going to be upon us very, very quickly. These last 3 weeks tend to go fast. Week 8 is a very short week, so make sure that you're looking at your due date. There's only one assignment. It's a reflection assignment, a discussion. You only have an initial post to do, but it's due by noon, 11:59 a.m. So make sure you're looking at those due dates, okay? I don't want those easy points missed. I hope you guys have a wonderful week, and I'll see you in the week 7 synchronous session and content session. If you have any questions, please feel free to reach out to me. And remember, email is the best way to contact me. If you can, use the inbox option through Canvas, because I have access to that on my phone at all times, and I can look at that a little bit quicker than I can the Outlook, okay? Thank you and have a great week.